Well, good afternoon, everybody. 11:30 on Wednesday, deep into this pandemic. We're happy to have everybody back with us today. This was kind of a tag on, an add-on to our webinar series that we've hosted with the University of Texas School of Public Health. And what we realized very quickly is that no matter what topic we were talking about or supposed to be talking about, the conversations and the questions started gearing always towards testing. What capabilities are out there? What do you recommend for testing? How do I get my employees tested and back to work? So we wanted to do an extra session on employee testing. What's out there right now? What is at the disposal of employers to test these workers, to get them back into work, or just to make sure that everybody's healthy and those people are not infected, or in general, what are the options for employers and COVID testing? So I asked our good friend, Dr. George Delclose, to jump on to another webinar today. So we're happy that you're here. We hope it's enjoyable and we'll keep it entertaining as usual. We definitely want to encourage the asking of questions. We're going to show a few slides up front just to kind of get a pulse on how are we doing. What are the testing capabilities? What are some of the new things on the horizon? But we want to leave the vast majority of this hour and a half webinar to your questions. We want to make sure that we answer as many things as we can. So there should be a question box on your desktop or on the app that you're using. Type in those questions and I can see them, and we're gonna answer as many as we can. Everybody is on mute who is an attendee, so don't try to talk because we can't hear you. But please type in those questions to that question box. Webinar series, if you've joined us before, but if you're new, welcome. This is hosted by the Houston Area Safety Council and the University of Texas School of Public Health here in Houston. Well, actually all over the states. We've had some of our experts in from San Antonio and El Paso, and George is in Houston, so we get a variety of locations and experts from those locations. But these two entities have brought together this webinar series, and we hope you've enjoyed it. We hope you enjoyed today's as well. Thank you to the many donors of UT. We could not do this without your support and your donations, as well as our sponsors from Houston Area Safety Council. We thank you for your support and your donations as well. Special thanks to our friends at Community Health First ER. When we first started this pandemic at the Houston Area Safety Council and ramping up testing, they were very instrumental on helping us get some of those testing supplies so we could test people. So thank you to those guys at Community Health First. So brief agenda today, we're going to talk all about testing today. What are the current trends right now? George is going to give a good update on that at the beginning, but what are the options? What is the FDA authorized under their Emergency Use Act that says we can use these testing kits and these testing supplies? What are those? What's on the horizon? We're going to talk a little bit about what are some of the CDC guidelines right now. They change, right? The CDC updates things, and we are going to talk about what the most recent guidelines are for that. And then, of course, our question and answer session at the end there. So I'm going to turn it over to George to talk about how we're looking right now. I think you're muted, George.
Thank you, Tommy, and thanks everybody for joining us again. If you've attended some of these webinars, you'll know that I typically start off with a review of what the situation is in the state, as well as locally here in Houston. It's been all over the news, so a lot of this is not going to sound new to you, but it is worth reviewing. So what we have on this slide is the daily number of cases in Texas, beginning back in early March to where we are now as of yesterday. So what we see, and connected to that is the line, which is what's been called the 7-day moving average of daily cases, because some days you're going to have more cases, another day you might have a few less than another one. And oftentimes when you hear it in the news, you'll hear them say, well, we've broken a new record, we've hit the highest number of daily cases. And that's important to know, But because numbers fluctuate, it's also good to keep tabs on what we call the 7-day average. So that's the average number of new cases in a week. And plotted onto this are the different measures that have been occurring in Texas, so that you can see their effects on the rate. So back in March, things were looking okay, but they started to rise. And down here, near just before the end of March, you see that the curve was starting to grow at that time. And you know, the way we were looking at it back then, those seemed like worrisome increases. And because of that, the shelter-in-place recommendations and orders were put in. It's certainly here locally in Harris County. And we saw that curve start to flatten again after about 2 weeks, which is usually the period of time that you want to allow for any given measure to see what the effect of any given measure, whether it's a protective measure, or whether it's a reopening measure, to see what effects it has. So 2 weeks, the curve started to flatten again. And then on May 1st, we began the statewide reopening, which progressed in phases. You probably remember that. And initially things looked okay. After 2 weeks after about the phase 1 reopening, numbers were a little bit higher, not unexpected, but not all that worrisome. And that allowed the state to go, this was about May 18th now, to go to phase 2. And phase 2 was kind of going okay towards just before the 2-week mark. The numbers started to look like they were increasing, and then Memorial Day hit. And then 2 weeks after, and then right after Memorial phase, that coincided with the phase 3 reopening. This is when restaurant capacity went up, bars were opened, etc. And you can see that very shortly after that, within 2 weeks, the curve starts really taking off. It's funny looking back at it now, those little increases, that what I call little increases now that we are seeing, because I'm looking at it with respect to the increase that we've seen in the last month, seem tiny in retrospect, but they were worrisome at the time. And now, of course, we're in the throes of a huge surge. So around July 1st, the governor hit the brakes on phase 3 reopening, and then we had July 4th. Numbers are still increasing. We still hit some new daily records over the last weekend, but daily increases in the number of daily tests is not the only parameter we should look at, because you might say, well, we're detecting more cases because we're testing more. So next slide. Our colleagues here at the University of Texas School of Public Health in the Biostatistics and Epidemiology departments have looked at this relationship between the increased number of cases, which you see in orange here, and the increases in availability of tests, which is in the blue line. If all of the increases that we were seeing were solely due or exclusively due to increase in the availability of testing, the orange and blue lines should be parallel. They are not. It is true that testing has gone up. It's stabilized over the last week or so, but the number of cases is outpacing any increase in testing. And that's important to keep in mind, because that tells us that whereas testing might explain some of the increase, it does not explain all of the increase. And actually, there are many other factors that explain the increase more so than just increases in testing. Next slide. So you have to get granular on these things. And another metric that we use to see whether increases are due solely to more tests being available or not is what's called the test positivity rate. That means out of all of the tests that you do, let's say we do 100 tests, the number of those tests that is positive, expressed as a percentage, is the test positivity rate. So as of this is the data from yesterday, but it's really from 2 days ago. In Texas, it is now 15%. Just to put that in perspective, that means that 15 out of every 100 tests that are done are positive for COVID. In general, we feel comfortable with reopening, or we should feel comfortable with reopening, and that things are under control, even if some cases are still appearing when the test positivity rate is at or below 5%. So we are 3 times that number. Now, if you look towards the end, so we were higher than this a few days ago, about 5 days ago. We were around 16.5 statewide. So that's gone down to 15 or so, which is encouraging, but there aren't enough data points right now to lower our guard. And I think that's what all of the authorities have been saying the last couple of days only, that there are some numbers that are looking a little bit better. Test positivity is one of them, although it's still way too high. Other things are like hospitalizations, which you've heard that the hospitals are at capacity, certainly in ICU capacity in many places around the state, but that seems to have started to level off a little bit in some places, but not others. Next slide. And this not others is important to keep in mind, because the numbers I've given you up until now are average numbers for the entire state of Texas. We all know that Texas is a big state, the biggest. Forget the ice cube up there in the Northwest. But so it is a big state with a lot of people and a lot of variability in terms of these average numbers, of how the numbers by counties relate to these average figures I just gave you. So for example, here blue is good, and white is even better. White means that there are very few to no cases, and these are hot spots. But then you start getting to the oranges and the red, and those are hotter and hotter areas in terms of areas where numbers are still rising. You have probably heard, because it's on the national news, that one particular area of concern right now is Hidalgo County down in South Texas. Very worrisome situation there. The numbers are still increasing rapidly, and the hospitals are overwhelmed there, including their ICUs. That is not the same situation in other locations. So we look at these state figures, it's important to know them, but then you as employers, or we as citizens, also need to take into account our local figures. If you want to look up your county, you can go to this website here, the www.texaspandemic.org. That's our School of Public Health dashboard created by our colleagues in biostatistics and epidemiology. And on the right, you can see the daily percent increase or decrease by counties. And this is a fixed photo, so I can't scroll up and down, but if you can scroll down to Harris County or Fort Bend or whatever, and numbers that are in orange or on the orange side of the scale, it tells you what the percent increase is day to day, and those that are in blue tells you what the percent decrease is, because there are some counties that are decreasing as well. Okay, so that's how you have to look at the numbers. Last slide, I think, for me is this one. And here locally in the Texas Medical Center, I've shown this slide before. We have a set of early warning signs that try to guide all of the hospital systems, health systems in the Texas Medical Center in terms of what can we do next when we see problems starting to rear their heads, so that we don't run out of hospital capacity, so that we don't run out of staff, so that we don't offer appropriate protection to our workers, the frontline healthcare workers. And these are these 4 indicators that we follow, which actually it's a little bit more. Some of them I've already reviewed. So the upward trajectory of new daily cases, which was the first graph I showed you, and the upward trajectory of positive rates, which I also showed you. I did say the last 2 or 3 days it's gone down, but what we do is, and this was from 2 days ago, we were still growing at that point. We're in the yellow zone. Yellow is not as good as green, but it's not as bad as red. With respect to it, another parameter we follow is the number of patients in ICUs who are COVID positive. So they're in the ICU because they have COVID. And that seems to have flattened a little bit over the last 7 days in the Texas Medical Center. That doesn't mean that that's what's happening in Hidalgo or in Tarrant County, et cetera. These are our local statistics. So we want to actually see this go down. That's why it's still yellow. But yellow is better than red. And there are plans in place should the ICUs be stretched. Again, we have plans in place to convert beds into more ICU beds that aren't normally ICU beds. So there is some wiggle room, but sometimes it's not only the beds that are concerning, it's having enough staff for those beds. And we have had a lot of healthcare workers out, not so much because they were positive, because at least in the Texas Medical Center, the overall numbers of infected healthcare workers compared to other places in the country, or frankly other places in the world, has been very manageable, very low. But there are many of these healthcare workers that are out because they're being quarantined, because they were exposed to somebody and they have to sit out 14 days before being allowed back to work. And that can drain, take a toll on your staffing levels. The good news is the same good news that I've been predicating for a number of weeks is that we are doing well in terms of personal protective equipment and testing in the medical center. We do a lot of testing here. That's where I spend most of my days reviewing test results on our university employees. So we're doing a lot, but the personal protective equipment is the one that I'm proudest of. We have had so many plans that we've put in place to make sure we never run out of N95s, of gloves, of gowns, etc. Sometimes we get close and then we figure out something else to do to bring some more in, or we work our way around it, but we have never been depleted of these very important pieces of equipment to protect our healthcare workers. So that's it for me, Tommy.
All right, thanks, George. Let's see what else is here. So I wanted to kind of give a brief update on, what's the state of the union with this virus? What do we know about its contagiousness today on July 22nd? So we look at the, how contagious is something? How likely is it to spread by a number that's called its reproduction or R0 number? And it's basically if one person has the virus, how many additional people do we think are going to catch that virus from that one individual? If we did nothing, if we didn't wear a mask, if we didn't wash our hands, all that good stuff. So when you look, we have this number for a lot of different contagious diseases. So when you look at the flu, we know that it has a reproduction number of about 1.3, meaning if I've got the flu, the chances are that I'm going to spread that flu to 1.3 people while I have that virus. And we know this number for a number of different viruses and diseases. Measles, on the other hand, is extremely contagious. So if I've got the measles, the chances are, on average, I may spread that to 18 more people while I've got the measles. So some numbers are smaller, some numbers are, like the measles, very highly contagious. H1N1 back in 2009 had a reproduction rate of about 1.5. So when we look at COVID-19, it's about 2.2 is what we think it is right now. And that number has been all over the place, right? When we first started, the World Health Organization thought it was up to 4 or 5%. And we've slowly come down on that number, which is great. So when you hear people say, well, it's twice as contagious as the flu, well, it probably is. From 1.3 to 2.2 is somewhere in there, but still, luckily, it's not as bad as something like the measles is. Here's a list of just some common diseases that we know of, and we know what that reproduction number is. So you can see measles, whooping cough, extremely contagious, a high reproductive number. And then when you get down to something like, HIV and AIDS, around 2.2 to 5%. Then you get down to malaria, and then, my gosh, malaria is high. SARS is up there. But this gives you an idea of those numbers of how contagious these diseases are. So we're going to talk about the testing availability and the testing options for employers. And I know George gets this question every single day. I get this question every single day. What can I do to make sure my employees are ready to come back to work? Or what can I do if an employee comes to me and says, I think I've got a fever, or I think I've got a cough, or I've got a body ache? What's available out there for me to have at my disposal for my workforce? So in general, there's two types of tests right now to test for this virus. One is actual viral testing, right? That's going to be a nasal swab or an oral swab to tell you, do you have the virus in your body right now? Are you positive or are you negative? The second means of testing we have is the antibody testing, and we're going to talk about the antibody testing and what it means and what it doesn't mean. But in general, you got two options. I'm testing for the actual virus in my body, or I'm testing to see if I've got antibodies built up because of the virus. I'm going to skip over that slide. So when we split these up, you've got two options for viral testing. One is the PCR, or the molecular. Some people refer to it as the molecular test. This was the very first thing that was made available to us to test for this virus way back in January. It's still what a lot of places and states use as their criteria for a positive or negative test. We had employees at the Safety Council that were flying to Alaska today. Alaska specified it has to be a PCR test for you to show that you're positive or negative. And that's mainly based on a couple of things. One is that the PCR is the tried and true gold standard test. But in addition, it was the only thing that was available up until recently, over the past couple of months or so. So when you see a lot of state requirements requiring testing, or site requirements requiring testing to enter the gates of their site, a lot of times you need to look at it because it may specify it has to be a PCR or molecular test. Good news is we have a few more options at our disposal now. The FDA came out and authorized the use of antigen testing. We use antigen testing a lot in clinics, and you just don't know it already, right? Antigen quick testing is done to test for the flu. If you walk into your doctor's office during the flu season and they run a flu test on you, it's an antigen test. If you walk in and they do a strep throat swab on you, chances are it's an antigen quick test. So the FDA came out and authorized new antigen quick testing for COVID-19. So there are places around that have the availability to run antigen quick tests now. We have one at the health center at the Houston Area Safety Council. We've run about 3,000 workers through that test over the past 3 weeks since we rolled that out. It's out there. And we're going to talk about the pros and the cons of each of those, because there are always pros and cons to any test. So we are going to talk about that shortly. And the second option for testing is the antibody test, and we're going to talk about what that means. So when you look at any test, and George, feel free to jump in at any time, you're looking at ways to test parts of that virus. The virus is composed of many different parts. When you look at a PCR test, the PCR test is checking for the RNA in that virus. You can see the RNA is that yellow squiggly thing inside of that virus. That's what the PCR checks for. When you look at the antigen test is checking for the virus on the surface of that, for the protein on the surface of the virus, those red spikes. So depending on what test you're undergoing or taking, it's checking for different components in the virus itself. Now this differs from the antibody test, and we're gonna chat a little bit about that now. So the antibody test is a blood sample test. It's going to check for past exposure to that virus, and if you developed the antibodies because of that exposure or that infection in the past. What the antibody test does not check for is if you're acutely infected right now, if you've got virus in your body right now. So the CDC has come out and said, look, antibody testing is great. We want to know if you've been exposed, and if you have antibodies in the past, that's great, but not the best solution to check for the general public or for workers to know if you've got the virus right now. It's not an acute test to see, is this person infected right now? It's to show, have I been exposed or have I been infected in the past, weeks ago, and have I built up any type of immunity to it? So like I said, pros and cons to every test, right? Every test is going to have has the ability to have false positives, false negatives, invalid conclusions. No test is 100% perfect across the board. When we look at the PCR test, that's the best test that we have out there. There are cons to it. It's uncomfortable. If you've ever had that swab before, it goes back to almost your brain inside of your nose, and it's not comfortable. It can take several days to get back, depending on where that sample is being run. If you're fortunate enough to have it done at a hospital, you're probably going to get it back within the day or so, or maybe 2 days. If you walk into a clinic and it gets sent off to one of the big commercial labs like Quest or CPL or CRL, they're running several days back. Sometimes I don't get that PCR test back for 10 days when I have to send it off to a commercial lab. So it can take at least a day or so to get back. On the flip side, the Pro, it is a very highly sensitive test. It's going to pick up minute forms of that RNA in your body for weeks. And we're going to talk a little bit about that, because sometimes that, that can be a fault of a test. Yes, it's great, it's sensitive, it's going to pick up if you're positive or you're negative, but it's also going to show you 3 months later if you still have virus floating in your body, and that can show up as a positive test. So I see there's some great questions coming through on the question board asking about that. Well, what does it mean if my employee tests positive that first week that they're showing signs and symptoms, but I send them back 2 months later and they're still showing positive? Well, it's because that PCR test is so dang sensitive, it's going to pick up specks of virus, even dead virus, floating around in your body weeks later. Now, does that mean you're still contagious? Probably not. And George can comment on that in a few minutes, but it's still going to show positive in your body. So it's a great sensitive test, but it does have that, so highly sensitive that sometimes that can be a deterrent for getting somebody back to work, because we're waiting on this PCR test to come back. It comes back positive. We send him 2 weeks later. It comes back positive again. We send him 2 weeks later. It comes back positive again. Well, what the heck? Is he still contagious a month later? Probably not, but it's because that test is so dang sensitive. George, any comments to that?
Well, you're going to talk about it later, but you're right. The reason that people can stay positive for weeks is because the test is sensitive, and there have been very good studies showing that after about day 10, and I know you've got a slide coming up about this, after about day 10 in a normal person, a normal individual, an otherwise healthy individual has gotten the COVID, there's very good evidence that even if you're positive, that when they do special tests to see if they can replicate or grow the virus, it doesn't grow. And that has led to a dramatic shift in the last several weeks in terms of what kind of criteria you can follow to return people to work safely, even if they are positive. We'll talk about that later.
The antigen quick test, definitely pros and cons to that as well. It's the same type of sample as the PCR test. It is a deep nasal swab. It is uncomfortable. It is less sensitive than the PCR test. It hovers around 88% sensitive, but highly specific when it comes to the positive. So that means if it shows you that you're positive, the specificity or the positive accuracy is around 100%. So it definitely has its pros. It has its cons. Definitely a pro is you can have that result back in a few minutes or hours versus the PCR test that may take 10 days if you go to a private clinic. So those are kind of the two options right now readily available, at least in this area, for you to know if at the time of testing you're sick, you're infected. Now, we do know, and I don't think I put a slide on this, but we do know from the time you get exposed to somebody to the time you're going to show positive on any test is several days. You can't get exposed to Aunt Sally at a family reunion on Monday and go on Tuesday and get tested and know for sure you're going to have a true positive result. You typically have to wait several days. And I know, what's the guideline right now in the medical center or where you are, George, for
right.
how long you should wait?
So it depends if you have symptoms or not. So if you've had an exposure to Aunt Sally and within 2 days you develop symptoms, you can test them right then and there because the incubation period ranges from 2 to 14 days. However, most folks are not symptomatic. They've had an exposure, they're worried they might get it, and so they want to be tested immediately. It doesn't make a lot of sense. By about day 5 is when you should start picking it up. So that in some cases here in the hospitals, we have people that are out just waiting to see if they develop it or not. If they have no symptoms, we sometimes will bring them back early at day 5 and test them. They have to be negative. But that's the reason we wait till day 5 is to catch it at probably when it's really likely to be positive, if it's going to be positive. But
Sure.
if they have symptoms, you can do it anytime.
Right. So I know there's some questions on, false negatives on PCR test, and that probably has to do with some of it, right? Well, if you test them too quickly, it's going to be a false negative, right? I mean, they do have virus in the body, but it's not enough to meet the threshold of the test being positive. So they may get, a fever the next day. You go and test them again the next day, and they're positive. So there is that window. I get asked that question a lot. My employee says he got exposed, or maybe he got exposed at work. When should I test that crew? And George just answered that question. If your crew doesn't show symptoms, you need to wait probably at least 5 days to get them tested, because you don't want to test them too soon and then end up with that negative test. So like we talked about, the antibody testing, antibody's great to show you if you have some sort of immunity. We're not sure what that means right now, but it does not tell you if you have the virus in your body at the time of testing. There's, depending on what antibody level comes back, maybe it can give you some indication of if this was a new infection versus an older infection. But again, it's not a good way to show if you're acutely ill at that time. You'd have to do one of the PCR tests or the antigen tests for you to get that result, if that's what you're looking at. A lot of debate right now and a lot of studies undergoing about, well, if I show antibodies, what does it mean? Am I immune indefinitely? Am I immune for a few months? Am I immune for just this strain of COVID-19? There's still a lot of ongoing discussion and studies right now about that. George, any insight into that?
So the insight in terms of what it means is that it is less and less clear what it means for a number of reasons. So antibody tests, in the same way that when you described the viral test and you said there were two types, PCR and antigen, not all antibody tests are equal, because an antibody is just simply something that the body manufactures in response or to block sometimes parts of the virus. But there are different antibodies because there are different parts of the virus. The best type of antibody test, which we do not have yet, is what's called a neutralizing antibody test. These are tests, these are antibodies that go to that part of the virus that is responsible for allowing the virus to enter the cell and to reproduce. And they exist, but commercially they're not all that available. So we use other things. And so if your antibody, once you have the infection, after a few weeks, most people will develop this IgG antibody that Tommy has here. And I would personally, there are two types of antibodies, one called IgM and one called IgG. Personally, I would ignore the IgM. I don't even order it anymore because there have been too many quirky results. But we do follow the IgG. This is the one that theoretically, at least in other viral infections, when you've recovered from a viral infection, you develop IgG levels that are high, and they last for a certain period of time. For some viruses, like measles, they last the entire lifetime. But for other viruses, like the flu virus, they only last from season to season because the virus mutates every season. With SARS, with the COVID virus, we don't know. We do know that most people will develop it starting at about 1 to 3 weeks after the infection. So as Tommy was saying, it's not good to use it for an acute infection because you have to wait at least a week for it to even have a chance of starting to build up, but typically it takes a little bit longer. And so when you see it, we know that somebody has had an infection, but now as more data gather, we're seeing different patterns. So for example, one of the more, I don't know, I wouldn't call it concerning because we don't know what it means, but we're seeing that some people that developed IgG levels that are high may lose them after several weeks. These are typically seem to be people that either had the disease with no symptoms or they had a very mild form of the disease. In contrast, people who were severely ill, maybe enough to go to the ICU or maybe even get put on a ventilator, when they develop their IgG responses, they tend to last a little longer. And so you got this trade-off. Well, what do I want, mild disease or severe disease? Well, I don't want severe disease, even if it does last forever, right? So anyway, that's one of the problems. The other problem is that we don't know what it means in terms of immunity yet, because not enough time has gone by. This is a new virus. We're only into it 5 or 6 months. I think, personally, my opinion, I think that once you've had COVID, I think there's a pretty good chance that you do have some level of immunity. I'm not so sure these tests necessarily reflect that. But I do know, I think there is some immunity, because one of the things that's been very rare or very difficult to demonstrate is reinfection. That, by reinfection, I mean you've had your first episode of COVID, you've gotten over it, you've recovered, and then you have a second one following another exposure. And I have yet to see one that I'm convinced. Now, that doesn't mean I haven't retested people that haven't been positive, but when I do the evaluation, usually it turns out to be a false positive. Or other times what it is you've had the acute infection, you've gotten over it, and then a few days later you come back and you're a lot sicker. What they call the cytokine blast, right? And that's not a new infection. That's the second part of that original infection, which fortunately happens in very few people. So the jury's still out on antibody testing. I think it's very important to look into it and to get the right antibody, but we don't know what it means, and we certainly don't know what it means with respect to immunity.
Here's a good illustration of, there were some studies done on antibody testing kits and how long after somebody was infected did those antibodies show up on those kits. And you can see, it's kind of hard to read if you're not used to reading one of these graphs, but the longer you went from being infected, the greater the likelihood of those antibodies were to show up on the test. So the vast majority showed up, greater than 20 days from infection. So again, not one of those things you can just jump out overnight and go get an antibody test and think it's going to show something. You got to wait, at least a week, like George said, for something to show up. I put this in here because we talk a lot about the PCR test and that being the best test. This was a study on 70 COVID positive patients in Singapore. They knew they were positive and they thought, well, let's just see how perfect this PCR test is, right? So they tested all of these people with one swab. It showed 88% positive. They tested them again with two different tests, 95% positive. Again with 3 tests to get to the 100% positive. So they're definitely, like we talked about, no test is perfect. It all depends on, well, how well did the swabber collect the sample, right? Did they get enough nasal sample on the Q-tip, on the swab, for it to run accurately, right? So there's a lot of things that go into play when you're swabbing somebody and running the test. But I thought this was a good study to show, it's still, even if you do the tried and true PCR test, doesn't mean it's always going to be 100% accurate. So CDC guidance on close contact, I get this question a lot. My coworker walked past me in the hall yesterday, or I sit across from him or her at the computer desk and we have a barrier. Do I need to go get tested because they're positive? Well, if you look at what the CDC defines as close contact, it's within 6 feet of somebody for at least 15 minutes at a time. All right, so passing somebody in the hall doesn't really meet that criteria. If you provided home care for somebody who is positive, well, that's going to be a close contact, obviously. But interesting, they put on here, if you had physical contact with somebody. So if you hug somebody, if you kiss somebody, if you touch somebody, they put this separate as 15 minutes. So if you walk up to Aunt Sally and give her a big smooch on the lips and you find out she's positive, it probably meets the definition of close contact by the CDC. So you need to be monitoring yourself and consider going to get tested after that 5 days if you don't show symptoms. If you share eating or drinking utensils from somebody, they consider that close contact. If somebody sneezed on you or coughed on you, then you forgo the 15-minute 6 feet distance, right? Now you've met the criteria under CDC of being in close contact with somebody. So just some good definitions to know and keep in your back pocket, especially if you've had an exposure at work or one of your employees has said, I sit next to John and he's positive. Well, walk through the steps of, does it meet the close contact definitions? And that'll give you a good starting point to know, well, what do I need to advise this fellow coworker? So, difference between quarantine and isolation. Quarantine means you think you've been exposed to somebody and you're going to stay home to make sure you don't get sick. And the CDC guidance for that is 14 days. If you think you've been exposed to somebody, or you've been exposed to somebody, stay home for 14 days, self-monitor, check for any symptoms, check for a fever. If after 14 days nothing arises, you're safe to go back into society or go back to work. You know, if you want to get a test during that period, great. You can go get a test, but still, like we said, the test can show negative, and you may not show symptoms for until that 14th day. So you still want to keep an eye on yourself for that full 14 days. Isolation, on the other hand, is if you know you're sick or you know you tested positive. Now you have to isolate yourself from everybody. It's the same concept as quarantine, but to differentiate it between those who are exposed to those who are infected, we call it isolation. And CDC just updated this guideline, days or the last couple of weeks. Isolate yourself for 10 days after those symptoms have started or after you've tested positive. So 10 days, because like we said, there's usually that 5-day window of no symptoms or you're not going to test positive. So in actuality, it's probably a full 14 or 15 days. You're going to be isolated from when you became infected. But from when you know you were infected by the symptoms or the test being positive, CDC says isolate for 10 days. So when can I escape isolation or quarantine? Quarantining after 14 days, assuming you never got sick. You can escape isolation after 10 days, assuming that you don't have a fever for the past 24 hours and all of your symptoms have improved. This is what CDC says is their guidelines and their recommendation for isolating, quarantining, and when you can leave that status. All right. So we're going to leave it there with the formal data and slides, and I'm going to go back. We've got some great questions that have come through. So, you know, this was a question, and I'll throw this at George, and I think we talked about it, so maybe it was answered, but it's a great question, a great scenario. Had an employee whose husband tested positive for COVID. He was asymptomatic. He was retested 2 weeks later, tested positive again 2 weeks later, and allowed to return back to work. Should this have happened? Is there ever a time when they test positive, but they're still allowed to come back to work?
The answer is, yeah, as we've discussed already, we've hinted at it, yes, this actually occurs quite frequently. So under the new guidelines that Tommy just showed, you said 2 weeks later. So if this person had no symptoms at the beginning, then you allow 10 days from the date of the test to go by. Sounds like that happened, at least, and even more. Sounds like it would have been maybe even closer to 14, but at a minimum of 10 days. And as long as they were still symptom free, they could go back to work. And even if they're positive, because of what we said earlier, that after 10 days in regular, otherwise healthy individuals, the likelihood that they are contagious is very, very low.
So, you know, and I know a lot of people, because it's been the guideline for so long, are still relying on PCR tests to indicate when somebody is negative. But like in this question, which was a great question, that poor dude is going to be positive for probably at least a month later, or maybe even up to 6 weeks later or 2 months later. So if you're relying on a PCR test to tell you when you're negative and using that as when you can go back to society and go back to work, it's probably very constrictive in when that person is allowed back to work. So assuming, go ahead.
Yeah, and I would say that this is true for general employers. CDC still does have the test-based return to work option available. In their most recent guidelines, they say that this should be the exception rather than the rule. But there are some circumstances where you really do want for somebody to be negative before they come back. For example, people in nursing homes, or people, healthcare workers that might have to work with very immunocompromised patients and things like that. So there are still some scenarios, but in the overwhelming majority of cases, you really don't need testing. You can just do this symptom-based, because a persistent positive PCR will lead to more confusion and more anxiety than is necessary. It will also lead to an unnecessary number of days away from work when somebody could be back at work. Now, one thing that's important, a lot of folks that I've talked to, they say, well, they're 10 days out. Well, wait a minute, it's not just 10 days out, it's 10 days out and no fever or symptoms for the past 24 hours. By the way, up until last week, it used to be 72 hours. But no fever or symptoms. So it's important that somebody talk to them, right? Typically, it's going to be their doctor or whoever your, employee, whoever the employer designated physician is. But they need to talk to these folks, because sometimes just talking over the phone, you can tell this person, yeah, the 10 days have gone by. This person is not ready to come back. They are dragging their feet. They are fatigued. They're not back, and a few more days would be helpful. So it's not just a cookbook approach. It really needs to be a clinical decision.
Right. Yeah, I will say that the CDC updated their website on this guidance on quarantining and isolation recently, and they've got some very easy to read calendar scenarios. So if you're living with somebody who is tested positive, it'll show you, okay, well, you need to start the 14 days from here. Now, if you get to day 13 and you're crossing your fingers, tomorrow's the last day I can escape. Well, if Aunt Sally comes to visit you and now she tests positive the next day, well, guess what? It's 14 days all over again. So if you go to the CDC website and just search CDC quarantining, that should pop up. It gives you some real life scenarios on those calendar dates and when you count and when you can stop the counting. Question was on, what percentage of positive tests are false positives? And I'll just kind of throw out, and George can piggyback. Of course, it depends on the test, right? Every test has its own sensitivity and specificity, and false positives and false negatives. So it really depends on what test you're looking at. What is the PCR sensitivity and specificity, George?
It's in the 95 to 99 range. However, so false positives and false negatives that doesn't depend only on the type of test. It is obviously very important, but on a bunch of other aspects related to the test. We mentioned before, you may have the best test in the world. If you test that person too early, it's going to be a false negative, even if they are infected, because you haven't waited long enough. If the person obtaining the specimen didn't do it the right way, they collected an inadequate specimen, it's not the machine's fault, it's the specimen collection fault, right? So there are a number of other factors that you have to cover to make sure that all of those steps are in place before you talk about what we call the accuracy of the test, their sensitivity, specificity, and accuracy. All things being equal, if everything is done properly, then for the PCR, the gold standard, it is very high.
Yep. The question was about, are we going to share these slides with everybody? Absolutely. If you registered, then you will get an email with all of these slides, a link to the actual recorded whole webinar. So yes, absolutely, we're going to share that with everybody. George, you talked about just commented on accuracy of the test. Talk a little bit about everything that I've shown as far as how to collect a sample has been to go to the back of the nose, to the back of the head, and collect that sample. But we do hear stories of drive-by testing facilities allowing the patients to swab their own nostril and just do the tip of the nostril. How accurate do you think those things are?
Okay, so to me, the gold standard is what you call it, the deep nasal swab. The technical name is nasopharyngeal swab, which means it goes through the nose to the pharynx. The pharynx is the back of your throat. So it's got to go from here all the way back till it hits the wall being your throat, right?
Right.
That's still the gold standard. It is uncomfortable, but it only lasts a couple of seconds, the discomfort usually. It has to be done right. It's not a matter of shoving it straight up. Actually, that's very wrong. You actually have to keep it horizontal. We ask people to tip their heads back. So we try to get that swab as horizontal as possible, and then it just glides naturally to the back. And you have to swab it and swirl it a little bit for a number of seconds, 10 seconds. I do 5, I do both sides. And it's not because I have a thing for torturing people, I don't. But I do both sides of the nose and I do 5 seconds each, but some people do one side in 10 seconds. There are other there are other ways, other types of specimens that are collected. One is a nasal swab where you don't go that far back. You may go halfway, what's called a mid-turbinate swab, maybe even outside the tip of the nose. Some people collect oral swabs. It's interesting, when we first started dealing with COVID back in January, the standard was you had to collect both a nasopharyngeal swab, and an oral swab. And then ultimately they figured out that that wasn't really adding a whole lot, so they just left it at the nasopharyngeal. CDC is now, excuse me, before I go to CDC, the other thing that is being increasingly used is collection of saliva. And there are some home-based kits now out there. It's important to understand that this is not like a pregnancy test. You don't take and spit into a little cup and then you do the test yourself, and you know the line either turns blue or it doesn't. It's actually just for the collection, and all the ones that are commercially available that I'm aware of, you have to send that off to a lab to be testing. Right. And that actually might have some, there might be some good support that that's an adequate way of collecting, of self-collecting a specimen. Why is self-collection of specimens interesting? Because if you can collect the swab yourself, that's one healthcare worker less exposed, because they don't have to collect it. You collect it on yourself. However, CDC has come out and they say you can collect it any of those ways. And this is my personal opinion, I wasn't too happy to see that, because I still think the nasopharyngeal swab is the best way to collect. Maybe followed by saliva, because with saliva you're getting enough stuff. Because at the end of the day, it's all about getting enough stuff, right, on the end of that Q-tip or that swab. So yeah, those are the different methods for collection.
A question came through about how are retests being counted with the county and the state? If somebody tests 4 times and they're positive 4 times, is the county and the state counting those as 4 different tests, or are they counting them as only one person being positive?
Yes, that's only one person being positive. They're counting new positives just like the rest of us are. And actually, as the need for retesting goes down because of these new CDC guides, that number should get closer and closer to being just the new positives. But yes, they only count new positives.
I know that when we test people, you know, we have to submit a form to the county, we have to submit a form to the state, and on there we have to specify, is this a retest or not? So I think that helps them distinguish. Yeah. There was a question about your map, George, the county maps. Let me go back to it. And the question was, if Harris County is you know, should be one of the hot spots with a lot of cases, 57,000 cases, why are some of the surrounding counties lighter shaded colors?
Right,
probably
because
has to do about
keep going. There. Okay, because, and the slide kind of got caught off, the part on the right. What it's showing here, there's a number of ways that you can look at variability or differences among counties. One is looking at the total number of cases of COVID from the get-go. If that were the case that we were looking at, and we are not, I'm going to explain what we're looking at here. If that was the case, then Houston, Dallas, San Antonio, and Austin would have big circles because more people live there, therefore there are more cases. But cumulative number of cases is not a good indicator of what's happening on a daily or a periodic basis. So we look at other things. And what we're looking at is areas that are hotspots. What this graph is showing is areas in which the day by day, it's the percent change day to day in number of positives. So for example, if you had 100 cases today and tomorrow you had 200, you would have 100% increase. That would be a fiery red spot, even if you're in a small county that has very few people. So in Harris County, if you look there, it's kind of a light shade of orange. That means it's still going up, but the percent increase day to day is not as big as it was before, okay? So it's always important to read the small print, and I had a feeling somebody would ask that, so I looked at it, made sure ahead of time. If I had the slide to do over again, I wouldn't have chopped off the title there on the right, but that explained it. But gotcha. This is day-to-day change. So we have a lot of cases in Houston. We have a lot of cases, and this is actually Harris County because this is by counties. But our day-to-day change in the last few days has not been as big as in other places. It's still been going up, but not by the same percentage as in other places.
Good question came up, and it's about kind of counting those quarantine days and when you can go back to work. But the caveat in this person's question was, well, how does a positive test throw a wrench in that, right? So if somebody's quarantining for 14 days because they got exposed to Aunt Sally last weekend, if on day 13 they start to get sick or test positive, that's when you start counting those days all over again. Is that right, George?
Yes. So here the critical thing is, do you have symptoms or not? If you have symptoms, even if you don't test for 2 days, if once you find out you're positive, you go back to what the date of that first symptom, and that's when you count 10 days forward. So let's say I developed my, what's today, the 22nd. Let's say I developed my symptoms on the 20th, 2 days ago, but I didn't think it was anything and I didn't get tested till today. My test today is positive. My 10-day count starts 2 days ago because I had symptoms. But we also know that there are people who have no symptoms. We call them asymptomatic, and they are yet positive. And when you're dealing with an asymptomatic person, you don't know when they started. They could have started 5 days ago. Maybe they started 10 days ago. Maybe they started yesterday. Since there's no way of knowing, what we do is we take the date of the test because there's nothing better. So I've been feeling fine, and somebody decides that I need a test, and even though I feel fine, I go and test, and I come up positive. My day one starts the date of my test, of my positive test, and then you count forward 10 days from there. It's a little bit iffy, but you got to start with, you got to have some reference. With symptomatic, it's very easy. The day they started having symptoms.
One of the questions that we get asked a lot, and we've seen this scenario, right? You've got two different types of tests, antigen quick test, we'll talk about that one, and a PCR test, right? They're checking for two different things on that virus. So it's likely that you may get two different results because of that. The PCR is very sensitive. It's going to check for that RNA in that virus for weeks and weeks after you've been infected, where the antigen test checks for something totally different. It checks for the protein on the virus. So so you may get two different tests, right? I may test positive on the PCR. I go get retested 2 weeks later. My antigen test is negative. If I want to do a PCR on that same day, the PCR may be positive. So then you got to kind of work with your treating provider to figure out, okay, well, what do these mean? I've got one showing he's positive. I've got one showing he's negative. What exactly does it mean? Should I do both? Should I get an antigen test and a PCR test done at the same time on everybody? Or if the antigen test comes back positive, should I do a PCR test? What would you comment on that, George?
It depends on the scenario. For example, when people come into clinics and things like that, like you said, the antigen test, if it's positive, it's 99% sure that the infection is there, right? So you don't need to act on it. If it's negative, depending on the scenario, I will sometimes send well, I don't do the antigen test, but for example, if somebody, here's a typical example, somebody has symptoms, very suggestive of COVID. They went somewhere, they got an antigen test, it was negative, I see them the next day, they've got symptoms, I'll send a PCR because I want to be absolutely sure in that case. So to me, a negative, although it's reassuring, a negative is less important than a positive on an antigen test in terms of relying on the result. But it depends. You know, they may be negative and they may be feeling fine and they had no exposure and I don't even know why they tested. I might just let it go with the antigen, or I tell them, look, if you develop symptoms, we'll test you at that point.
Right. There's a question from one of our good friends here at the Safety Council asking, when I think it was the slide on testing, testing versus cases. Let me go back. I think it's this one. And the question was, do you mean, is it testing availability on this slide or actual testing being performed?
It's testing, actual testing being performed. These data come from the state health department. So we're just using their data to construct our curves. And again, this is not total number of cases, it's percent change, okay? So again, if you look at the orange line, this is the percent change from yesterday to today, today to tomorrow, tomorrow the day after, and you see that the numbers are still going up. We know that that's happening in Texas. The total number of cases is increasing, the percent change from day to day is going up. Yesterday I had 100, today I had 110, tomorrow I have 130. Okay, same thing with the tests. It's not that the number of tests that we're not doing more testing is that we're not necessarily increasing. We've hit a point where it's flat. We're doing the same number of tests every day, and that may change. There's a lot of reasons for that. It might be availability of tests. It might be tests that for whatever reason, there might, there still are shortages of supplies in some places in Texas. Fortunately, we don't have that problem, but it's not enough to just say, I've got the test machine and I've got the little swab, because there are other parts to it. There might be a medium, the liquid that you're supposed to transport it in, or you may run out of swabs and things like that make doing the test not feasible.
The question from one of our good colleagues was asking, is the antigen test result reportable to public health authorities like the PCR? And the answer is yes. We have to report those, and they do with them as they please. But yes, we do have to report those test results. Another question. Can you comment on the saliva test for PCR availability in Houston and Texas? I haven't seen it readily available in the Houston area. George, have you heard?
No, I haven't seen anybody collecting. And again, it's a collection system, right? I know that in other countries they are using saliva home kits. I was listening to a presentation yesterday from some investigators in Australia, and I know that they are still working on the ideal, but it's a home collection kit. I haven't come across any saliva samples. I've personally done a few oral swabs in people who had been tested so many times through the nose that they were actually getting sore and things like that, and they were reluctant to be tested. And then in those cases, I did an oral, but I haven't done saliva.
Just a general question and just asking for a comment. What are your thoughts on the CDC rolling back that 24-hour, from 72 hours to 24 hours with no symptoms, fever and no symptoms?
Well, two parts of the answer. I was kind of miffed because we had just made the switch at the university to go from test-based testing to the return to work based on symptoms, which was 10 days and 72 hours. And then when we were just getting that implemented, here they come up and they say 24. I'm going, oh, geez. Because every time you implement a change, and employers know this very well, you don't implement it on one person. You have to apply it to your entire employee population. And so when you roll out, if you're hitting people constantly every week with, oh, we changed this, we changed this, we changed this, they get confused. They get they get a little bit upset sometimes. And so the timing of when you introduce changes is important. So I was a little bit miffed with that because we're still going through the implementation of the last one. Having said that, I then thought about it. Most people that reach day 10, if they've been asymptomatic for 24 hours, the majority of them will also have been asymptomatic for 72.
Yeah.
But again, I think this is where the phone call is important from the clinician, the phone call or the visit or whatever system you have from the provider, because talking to these folks to make absolutely sure that that they meet the criteria and that they really are doing well is very important. I've spoken to many people at day 10 or 11 and asked them, how are you doing? And they say, "Lo, I'm fine. I think I'm ready to go back to work." And I can just hear them over the phone. I know they're not ready to go back to work. And so I would apply the same thing here, even more so since it's only 24 hours. It's probably okay. CDC doesn't usually issue guidelines unless it has data behind it. So I do, that is reassuring to me, but the timing was pretty bad.
I know I did see, and that question came through asking about this, but I did see on their website that they no longer recommended using a test-based system to return to work. And I think that's what we're talking about. But, they want you to follow those days. If you've gone through the days, you've gone through the 14 days or the 10 days and your symptoms are better or no symptoms, no need to get a test. So that was their updated recommendation. It's nice to have a test, in my opinion, to know, positive or negative, but the CDC says you don't have to hang your hat on a test.
Well, they recommend it strongly, the symptom-based test, but they haven't removed the test-based strategy. They still do say that in some cases it might be useful to do. I alluded to some of those earlier, like in nursing homes or
weakened immune system.
Very vulnerable patients, right?
Yep.
Tommy, I had a question for you. It's actually a two-part question. It relates to two things that were asked. First is, yes, you report to the health department. So do you know if the health department is counting positive antigen tests in their total case? And the reason I ask this is because before mid-May or so, when you saw positive results from the state, they were actually counting, they were mixing
Right.
PCRs and antibodies.
Antibodies, right. Exactly.
They stopped doing that, but
Right.
that does raise the question about the antigen. And then the other question is,
Yeah.
do we know if antigen tests remain positive the same way that PCR may remain positive for a long period of time?
Yeah. Two good questions. And I just saw recently where the state, at the state level, removed the antigens from the total count of positives. And I think what they're going to do now, because they were mixing with the PCR, so they said, well, apples to apples, let's remove it. So it looks like they're going to start reporting those just kind of separately off to keep it consistent, because they've been reporting PCRs all along. So at the county level, I do believe they're still counting the antigen tests in, mixed up with the PCRs just as an overall positive. And the second question is, I'm not really sure about how long that antigen positivity will keep showing up. I just anecdotally, we've seen, where after the 2-week mark, the antigen will be negative. PCR is still going to show positive. So that's, just anecdotally, but haven't seen any major studies on it.
Yeah, I haven't seen anything either. That's what I was asking you.
Yeah. Let's see. Can or should an employer recommend antigen versus PCR versus antibody when sending an employee to the clinic? Can an employer recommend or set guidelines, or this is the test I want to see? What do you think about that, George?
I think you're the expert.
So yeah, I mean, in fact, we had a labor attorney on one of these panels over the past couple of them, and that question was asked: can I require an employee to have a test done? And she said, absolutely, you can. If that is part of your safety program to require a test result to show negative, then by all means you can do that. Can you determine what that employee has? I mean, yeah, I think you can. Employers are absolutely doing it. And when we asked the attorney, she said she didn't see any problem with it. Whatever you think is based on good data and good science is a valid test to have run on that employee to assure a safe and healthy workplace. Then it looks like the answer is yes, you can.
So what I've heard, I agree. I think that tests for active infection, antigen and PCR, employer has the right to require them. Another issue is, what are you going to do with the result, especially if it represents a persistent positive? But I think the jury is still out on whether employers can require antibody tests. What I have read is that they cannot. But that might be a good question for your labor attorney.
Right. No, I agree with you. I believe the ADA had said, antibody test, not the best way to test somebody, but definitely the PCR and the antigen test, absolutely. I think we kind of answered this, but it was asked again: how long after an exposure before somebody tests positive and is contagious? So it definitely varies, that 2 to 14 days. So it just, that's the answer. It definitely can vary.
Yeah, let me add a little bit to that. So 2 to 14 days is the range from the very beginning that CDC and World Health Organization have been using to identify when the earliest following an exposure that somebody might develop symptoms or become contagious, which is day 2, and what is the latest. And they set the latest at 14 days. In reality, I think the longest a person has been actually the longest for the incubation period has been around day 12. They added those extra 2 days just as sort of padding as a safety measure. However, the majority of people, the median, as they say, the majority of people will develop symptoms or become contagious between day 5 and 8. Some places say between days 5 and 9. So it's like a bell-shaped curve, right? So some people can start getting symptomatic really, really early. Most people take a few days, somewhere between days 5 and 8 or 9, and then a very, very few people might not get it until day 10, 11, or 12.
Excellent. How sensitive are the rapid antigen tests? Sensitivity is about 88%. Specificity, meaning the accuracy of the positive result, is around 99 to 100%. So there's your sensitivities and specificities for the antigen test. How long after the virus is in the body will the antibodies develop and show on a blood test? I think we covered that, but it definitely takes at least a week before you can be confident that, you know, it's going to be accurate.
Well, 1 to 3 weeks for the IgG. The IgM starts appearing a little bit sooner, but like I said, it's not a very trustworthy test. And even if it was, we don't know what it means.
Right. Right. Let's see, on the guidelines for employees going back to work after being positive and being sick and isolated at home, what is the best guidance you suggest? And you know, and the question was, should they do 2 negatives later after the 24 hours apart, like the CDC recommended, or what are some recommendations we can give?
So if we go by CDC, they're encouraging employers, with some exceptions, but most employers, to go use the symptom-based or time-based return to work strategy. That means person gets sick, you count 10 days from the day their symptoms started. At day 10, you ask, you send them to a doctor or a provider, and somebody that can review it with them, ask how they've been doing the previous 24 hours. If they haven't had any fever or symptoms, they can go back to work. If they don't have symptoms, but you still know that they were positive, then you use the date of the test, the positive test result. You count 10 days forward from that, and then they can be evaluated in the same manner. If there's no fever, no symptoms for 24 hours, they can go back to work. And then there are some scenarios where testing, again, especially if that employee is going to be going back to an environment where he or she might be exposed to, might expose vulnerable people, vulnerable patients, very sick patients, for example, nursing home, transplants, et cetera, where the test-based strategy might still be a reasonable option.
Good question came in. I think we touched on it, but not specifically to this question. And the question was, you know, some clinics are recommending, well, if you do a quick antigen test and it's negative, you should also do a PCR test. And George, you commented on it, but I think it depends on, and actually the guidelines from the manufacturer say, if you highly suspect somebody is infected, they've got a fever, they've got body aches, they've got a cough, they've got everything under the sun, or maybe it's just one symptom, and the antigen test shows negative, it's possible that it's a false negative test, and then you should consider doing the PCR test, which is more sensitive. But if you're just testing routine people, no symptoms, they've had no exposure, and the antigen test shows negative, then you can be, 90% confident that it's a true negative test.
So I would add to what you said, not only the symptoms, but have they had a confirmed exposure? In terms of the first part of how you answered it. So if somebody has, an exposure that really kind of it was a real exposure. They were close up, people were coughing all over them, et cetera. They later found out that person was positive, then my index of suspicion and maybe wanting to do another test would go up. But if they don't have the exposure, and on top of that, they don't have any symptoms, I agree with you. I mean,
sure,
you might as well take it at face value.
Absolutely. There was a question from a good friend of mine, Georgette, but I bet you, Georgette, we probably can't answer this one because it has to do with that FFCRA guidelines for pay. I don't know, George, if you're an expert in that realm or not.
No way.
No way. So I will get that answer to you from our HR because we've definitely had to answer that question a lot via HR, but I'll get that to you. Let's see here. So the question was, are employers allowing an antigen test as a basis for returning to work versus waiting the full 14 days? And yes, they are. They certainly are. They're certainly, doing the PCR test as well to get out of that 14 days. But just know, as we've talked about, you can test somebody on day 10 and it can be negative on both a PCR and antigen test, and on day 14, they start to have symptoms and then are positive. So yes, you can. It's a good way to screen, but they still should continue to self-monitor If they're an essential worker and you need them back to work, they self-monitor, check daily for temperatures, even after they've tested negative. Would you concur with that, George?
Yes, actually, all of us should be self-monitoring, even if we haven't had the test.
Right.
And even if we are still at work. I mean, I have no option. Every day I walk into the hospital, I get zapped with the temperature thing and I get the questions asked. But even if you don't work in a hospital, we should all be aware of what the symptoms of COVID are. And by self-monitoring, we don't mean you report it to anybody. You're just aware. You pay attention to symptoms. You may want to take your temperature, things like that. I think that's something everybody ought to be doing.
Right. I did see, and George, I'll ask you this so you can keep it unmuted. You want to talk a little bit about the studies on blood typing and more in certain blood types more susceptible to this virus versus not?
Yes, and I forget which ones. I think mine is more susceptible A, but
Right.
from what I've read,
Yeah.
yeah, I've seen those reports. I have to be honest and say that I haven't spent a lot of time on them, so I don't know what the underlying rationale is. Maybe you do, Tommy. I have seen the reports. You know, a lot of times, and this is less my physician background and more my epidemiology background, we see two things that relate to each other. That doesn't mean one causes the other. We call those associations, not necessarily causes. And we can find a lot of associations in a lot of things, so that doesn't mean that they're necessarily causally related. So you need to do more research to understand it. And one of the important things, and it's probably been done if they've published these articles, is to me, it's not enough to tell me, hey, more people with group A blood type get severe infections after I control for everything else. It's also important for them to explain to me, well, what would the mechanism be? How would that lead you to become more, you know, at greater risk of having a severe infection? We can do that for obesity. We can do that for diabetes. We can do that for people who have underlying heart disease, because we've known for a long time that people that get infections and have these conditions, especially underlying heart, lung disease or diabetes, are going to have a worse time of it. This may be the same type of association, of explanation, but I don't know what the explanation is for the blood type. And I'm not saying it doesn't exist, it's just I haven't gotten into it that much.
Yeah, I saw the same study, George, and it said if you blood type A was more susceptible, blood type O was less susceptible, but you know, I would take it at it's with a grain of salt probably until we know more.
Or another way to say it is, when I saw it was blood type A, which is my type, I stopped being interested in the article.
Yeah, there you go. There you go. You know, a good question was, you know, well, if we tell employees that, hey, you just got exposed today, you need to wait 5 days until at the earliest we would want to test you. You know, how do you lessen their anxiety during those 5 days about bringing it home to grandma or bringing it home to the kids? What recommendations would you give, George?
Those people have to isolate. I mean, for starters, they should be in isolation. If they've had a known exposure, the CDC says if you're not going to do anything, it's 14 days. If you want to test them with all the risks that you explained, and you know, here in the medical center, we sometimes have to bring these folks back earlier than with the 14 days because we need them. I mean, because there are staff shortages. We have to have nurses, we have to have doctors. And so we will do it at day 5 to allow that period of time. But ideally, we should actually, the safest thing to do would be to leave them at home for 14 days. But some people, you really can't afford that. So we bring them back cautiously. And the way we do it is bring them back at day 5, make sure that they have no symptoms. And remember, a hospital environment is very different maybe from other types of businesses or industries. So we bring them back at day 5 and we have them self-monitor. And if they even sneeze, they get retested. But more important than all of that is we protect them. We know that masking works. We know that eye protection works, as long as you do it right. And as an example of that, and even though I don't have the numbers, you know, most of the cases that we are seeing of infected healthcare professionals here in the medical center are not coming from the workplace. They are mostly coming from outside, from the community, or it's not known. And they bring it into the workplace, and then they might infect a coworker. But even we have relatively little coworker infections because I'm not saying we put them in moon suits, but we protect them. and which means that we're also protecting others from them. And and you don't always get that in other businesses. Yeah, people are wearing masks, but you all have to realize that in the hospital, we add layers of protection. You know, the bandana ain't gonna work in a hospital. It has to be a surgical mask at a minimum, or an N95 in certain circumstances. We now have, everybody has to wear eye protection, face shields. That's not common in the community. So we bring them back carefully, and we bring them back in such a way that we protect them and others from them.
Mm-hmm. Thank you for that, George. Question was related to an antibody test, but I'll answer it in more general terms. The question was, does the antibody test differentiate between different strains of the coronaviruses? And so the answer is, it depends on what test you would have and who the manufacturer is, and have they gone through all those steps to assure that if you do get a test done and it's positive, that you know it's not a coronavirus that causes the common cold, right? It's specific to this SARS-V2, you know, what this specific strain of coronavirus. So yes, the ones that are out there that are FDA authorized have gone through those motions to run trials on multiple different coronaviruses and other viruses to make sure you don't get a false positive due to another strain of the virus. George, you want to add anything?
No, I mean, that's correct. There are 7 different types of coronavirus out there. The last time I checked, 4 of them are responsible for the common cold. And then we have SARS, MERS, and SARS-CoV-2, which is the one we're dealing with now. And you know, they all belong to the same group of viruses. They have these little spiky things. That's the corona, right? The crown. When you look at their genome, they have a lot in common, but there are certain areas of that genome that are unique to each of the 7 types, and that's what the PCR goes for. Those unique areas that are unique for the COVID-19 virus. And that's what allows them to not be confused or not test positive for other coronaviruses.
One of our colleagues asked, are neutralizing antibodies, are they also from the IgG type, or what type of antibodies are those?
They're called neutralizing antibodies. I don't know what type. I know that that's the name for them. When you develop a test for them, they probably are IgG. I don't know that for sure. But the reason that they are so interesting is because they neutralize the virus, right? Like you were saying, antibody tests, you can develop the body develops an antibody towards probably a whole host of different antigens or proteins on the virus. Not all of those interfere with the ability of the virus to replicate. Neutralizing antibodies do too. And if you'll allow me a little bit a segue, one of the things that makes it difficult to understand whether IgG reflects immunity or not is because it seems like the body's response to this virus activates 2 different parts of our immune response. One is what we call humoral immunity, and that's the one that is that antibodies that's when our body creates antibodies to the virus, and those antibodies are effective at neutralizing the virus. And so you develop a test for that, and you can measure that, right? But there's another type of immune response called the cellular response. It's directed by another type of white blood cell called a T cell, and that is not picked up necessarily by an antibody test. The reason that is so fascinating to me is you have this dual response. The antibody may just tell you about half of the issue, and so that could explain, for example, even in people whose antibody levels fade over time, maybe they are still immune because of this. You know, because their immunity has been developed through T cells. Y'all probably heard a couple of days ago that Oxford University and Cambridge has come up with a new vaccine that seems very, very promising, but it is different from the other vaccines that are also showing promise that are being developed. Like in the US, you've probably heard of the Moderna lab, which is working with NIH to develop a vaccine. The interesting thing about the one at Oxford, the majority of other vaccines that are being developed are targeting this antibody response, right? The humoral response, which may be all that it takes to protect you. But the Oxford vaccine, interestingly, appears to affect both of them. It blocks both the cellular response
Right.
as well as the the antibody response. So you get a double whammy. So we'll see. You know, most of the time in vaccine research, you get really hyped up about something, and then when it's put to the test, yeah, it doesn't
Yeah,
work out. But
yeah,
I thought that was pretty interesting because that's different from some of the other
it is.
vaccines being developed.
That's great. Some promise there, hopefully. A question was just on process and protocol for the safety council. Can I send my employees up to the council to get tested? Yes, absolutely. We got the whole shebang full of testing, so we can do the PCR, the antigen, the antibody, whatever the case is. We have full capabilities of doing that as well. Um, let's see here. I think we've got about 4 minutes left. I think actually our invite said till 12:30, but we went ahead and lasted through till 1, but I'll be respectful of everybody's time. There's a bunch of questions still left unanswered, and what we typically do, we're going to send these slides out to everybody who registered, as well as the link to the recorded webinar. And then in addition, when we have unanswered questions, we'll put those in a spreadsheet with the question and the answer next to it. So that way we answer 100% of everything. Let's see here. Let me see if I can fire shoot some of these here. Talk about, I saw in the news, and you and I briefly chatted about it via email, George, but pool testing now at the labs. What does that mean, and what does that mean for the backlog of the testing?
Yeah, it's very interesting. We're still trying to figure out the best use. So y'all have heard that there are shortages, right? That there's not enough testing for various and sundry reasons. One of them might be that there aren't enough testing labs or testing reagents out there. So one of the interesting approaches to maximize efficiency is what's called pooled specimen testing. And this has been done before. It's been done for HIV. It was done for Ebola, I believe, and some other infectious diseases. So if you want to save on tests, what you can do is you can take a group of people. Let's say you've got a crew at a construction site, 5, 6, 7, 10 people, and you want to know if there is active infection in those 10 people. You can test each of them individually, which is what we normally do, and that means 10 separate tests, or you can get specimens from all 10 of them, put them into one bucket, for lack of a better term, and then just test them at the same time all together. And you're going, well, that's kind of weird. Well, no, not necessarily. If that test comes up, that test, which is the pooled test reflecting 10 people, comes up negative, then you can say everybody in that group was negative. I can move on to another group of 10 workers, for example. So with running one test that consists of 10 specimens, and 10 is just a number I pulled out of the air, you've got your answer. If instead of negative, there is a positive, it comes back positive, then somebody in that group of 10, maybe more than one person, but somebody in that group of 10 is positive. So then you have to go back and test each person to see who it is. But in the majority, especially in areas where the disease is not very prevalent, that means that a low percentage of the population, only a low percentage of the population has the disease, pooled specimen testing might be very reasonable because the chances are very great that you can test large numbers of folks and everybody will be negative, and then you only have to test individually when one of those pooled specimens comes up positive. The other day, the FDA approved its first pooled specimen testing lab, and that was Quest Lab, but they are calling a pooled specimen 4 tests. So I don't know if you get as good a bang for the buck from 4 than you would get from 10 or 20. I mean, intuitively, you would not. It's got to be done right. It sounds like a great idea, but there are problems. So the collection is very important because you're putting a bunch of specimens, pooling specimens, and you have to make sure that you get enough stuff from each of those 10 people for the test to be valid, that the specimen isn't diluted. But they've done some comparison studies, and PCR is so sensitive. And by the way, you got to do PCR with this. This is not for antigen and certainly not for antibody testing. But PCR is so sensitive that even with dilute specimens, it picks it up. So it's something to keep an eye on. I know that CDC has been talking about it, and FDA has as well, and Dr. Fauci has been talking about it. I'm reviewing a paper right now for a journal that looks at this issue, especially in terms of being used in business, places of business. Can't say anything about it because the article needs a lot of work still, and it's not mine. I'm reviewing it. So, but that's kind of where things are. So keep your eyes out for that. It was pretty effective for HIV a long time ago.
Good. Excellent. Well, we're at the 1 o'clock mark. I'm going to ask this final question. I think it's a real life scenario. Employee and his family all test positive after a vacation. The employee has no symptoms, but all the other family members are. After the 14 days, so they all test positive, right? So after the 14 days isolation, the employee does another test. He comes back negative. Everybody else in the family is positive. Can we allow that person to go back to work, or do we need to keep him at home because everybody else is still showing positive? I think you're muted, George.
Oh, sorry, I did it the other way around. This person was positive originally, right?
Yes. Yes.
Yeah, he can go back to work. That's not the problem. The problem is when everybody in the family except that worker is positive, right, and then you don't know when to start counting, because right, unless you isolate the negative employee, the employee who tests negative, completely from the rest of the family, and then you start counting 10 days from there or 14 days from there, you don't know when. And yeah, actually, this happened very close. I hope he doesn't mind. My son. so my grandson, who's 1 year old, and with this I'll finish, was exposed to another kid in daycare, and he developed symptoms a few days later. He did not test, but because they didn't know that there had been a positive exposure in the daycare. But a few days later, 3 days later, they got a letter from the daycare saying it was positive. And then my daughter-in-law that day developed symptoms. She was positive. So it's my daughter-in-law and the baby, and then my son. My son, they're already back to, well, the kid's not back to work. He's not employed. He's only 1 year old. You know, my daughter-in-law is back to work, but my son has to continue, even though he's asymptomatic. Maybe he got it, but he has to continue and complete 14 days from the day that my daughter-in-law was released to go back to work, because his exposure to her continued every single day. Yeah. Had he been able to remove himself, then the clock would have started differently. But a 1 year old, there's no such thing as social distancing from a 1 year old.
Yeah. So. Yeah. Excellent. Well, I knew this was going to be a hot topic today, and I think we have probably around, I don't know, 50 questions left unanswered. So we will get all of those answered and emailed out to everybody, so everybody can have both the recorded webinar to look at as well as the spreadsheet of unanswered questions. So again, we thank you. If there's another topic that you would like us to do, feel free to email us at the Safety Council, and we will be happy to roll something out if we at all means can. But I hope everybody stays safe and healthy, and let us know if we can be of assistance with anything that you might need. Thank you, George. Appreciate it.
Thank you, Tommy. It's always a pleasure. These are fun. And thanks, folks, for putting up with us.
Absolutely. Take care.
Take care. Bye.
Bye-bye.